Hi, my name is Melissa Creary, and I'm an assistant professor in the Department of Health Management and Policy for the School of Public Health. Sickle cell disease is the most common inherited red blood disorder, not only in the United States, but also globally. Some of the characteristics of the disease include the experience of lifelong um, complications that include stroke, acute vaso-occlusive crises, um, problems with pain more chronically. If you can imagine that blood flows everywhere, that means that the body, anywhere that blood flows, can be potentially affected by sickle cell disease. Some of the long-term issues include organ damage, which can lead to death and other comorbidities. Sickle cell disease is a single point mutation that affects about 100,000 people in the United States, primarily those of African descent, although the disease affects those of African descent, Mediterranean descent, and Asian descent. So we can think about this in terms of populations in the United States. This impacts primarily and disproportionately African Americans, as well as some Hispanic populations, and very rare, but not unheard of in white populations across the United States. Individuals living with sickle cell disease are primarily diagnosed now, currently, with newborn screening. So newborn screening is able theoretically to catch most of the cases that occur if you're born in the United States. Of course, this doesn't account for any migrant populations that may not have had appropriate testing in their country of origin. So, complication is once these children grow up and they leave the pediatric healthcare system, healthcare becomes more fragmented, and this fragmented care means that more patients living with sickle cell disease fall in the gap. This also gets exacerbated because of insurance complications and the transition between young adults and adolescents into adulthood often means that there's an increased use of emergency department visits as opposed to the well visits that may have been centered during childhood. So the ACA is very helpful when it comes to ideas around the insurance, at least being expanded until age 26. This helps give an expanded period of time in which those living with sickle cell disease have more time to figure out their course of care as they enter into adulthood. Another complication around those living with sickle cell disease is the demographic of the population itself. So no other chronic disease has the kind of profile in terms of geography, in terms of economics, in terms of comorbidities that are a part of the package of having sickle cell disease. And so what this means is that more people who are living with sickle cell disease are on public insurance, Medicare or Medicaid. What this means is that the SES of those living with sickle cell disease are lower than average. What this means is that the majority of people who are living with sickle cell disease nationally, more than half of that population live in the South. And so the implications of Medicaid expansion, for instance, have a great impact on this population. Another complication involved with sickle cell disease is this idea of high utilization in the healthcare system. And of course, with high utilization usually comes, specifically with this population, are high treatment costs. So when we think about the costs associated with sickle cell disease, on average for children, it's an annual cost of $10,000. For those who are adults, it's about $30,000. And if we calculate the amount of money up into 45, that time span between birth and 45, an individual can accrue near $1 million in costs and healthcare costs. So if you think about the kind of patient profile that this kind of presents to the system, typically very underserved, low income, and high presenting in terms of their experiences in the healthcare system. All of these factors kind of create a maelstrom of vulnerability for this particular population. A recent study using Medicaid data and covering 5 states have shown that adults with sickle cell disease tend to use inpatient services more, tend to rely on the emergency department, and overall have a really increased number of healthcare utilization numbers. And this is in comparison with pediatric patients. Another recent study has shown that since the implementation of the ACA, however, that adults between the ages of 18 and 25 tend to not rely on the emergency department as much and instead take advantage of private insurance as maintenance for their disease. So when we think about sickle cell disease and we think about this idea of transition from pediatric to adulthood, what's happening on the pediatric end is that it's a really safe place for coordination. And so because sickle cell is a disease that affects the whole body, we've got folks who are specialists in blood, folks who are specialists with lung and kidney. We've got nursing services and social services and psychological services all kind of tied together in a nice bow for those who are in the pediatric system. We tend to lose all of that once we become 18 and adults for those living with sickle cell disease. And so this really prime safety net that they've had for many years, in addition to parents who can usually advocate for the children themselves, they are become more lost in the system once they become adults. And this is why the ACA's expansion for children to be underneath their parents' insurance up until 26 is so key for this population. The ACA presents a number of opportunities and challenges for those living with sickle cell disease. First and foremost, the Affordable Care Act has allowed for millions of people living with different disorders and diseases to be counted and, in terms of pre-existing condition. So before the ACA, if you had a pre-existing condition, you were not able to receive coverage. And so this has been an amazing feat, I think, for the Affordable Care Act, particularly for this population. The idea that insurance is a possibility and that coverage is a possibility is a great boon for those living with sickle cell disease. The fact that the Affordable Care Act now offers at no cost preventative screenings and other preventative tests like relevant vaccinations for this population and newborn screening in particular. The fact that this is no longer at a cost for the patient population is an amazing thing being offered by the Affordable Care Act. And newborn screening is essential in terms of catching those diagnoses early and getting the pediatric and infant population into care as soon as possible. I think that the Affordable Care Act's emphasis on expanding access to care via community health centers is something that can be very useful for those living with sickle cell disease. Community health centers are known to interact with at least with a large population, and of this population, 2/3 are people of color. And because of the demographics of sickle cell disease, the likelihood is that those who have sickle cell disease can encounter health through this arena as opposed to entering emergency room departments. So this can fill a potential gap. So, as much as the Affordable Care Act offers us opportunities for those living with sickle cell disease, it also provides some challenges for us to think through as well. One of the challenges is that the ACA will not enhance access to care for those with a chronic condition, including those living with sickle cell disease. In addition, the law will not reimburse for intentional coordination of care. And as discussed previously, this coordination of care is crucial for this particular population. In addition, one of the major coverage provisions of the Affordable Care Act is Medicaid expansion. And this is expansion for vulnerable, low-income families who have a family of three with an income level of less than $28,000. To date, no southern state has incorporated this Medicaid expansion for its constituents. And what this means for sickle cell disease is because nationally, more than half of those living with sickle cell disease reside in the southern states, they are not eligible for this extra coverage that Medicaid provides through the ACA. So, if we can think about sickle cell disease being a vulnerable population, and connecting that with the fact that racial and ethnic minorities tend to have less coverage than their non-Hispanic white counterparts, then we can think about how the stripping of the ACA would do even further damage to that population. So this means that the provision of being on the insurance gets taken away. So this means that there's no longer a catchment system for those that are transitioning from childhood to adulthood. This means, I think most importantly, the idea of a pre-existing condition being brought back up as a barrier to coverage in the first place. I think that the pre-existing condition clause is amazingly important for this particular population in terms of allowing them to even have access to the marketplace to begin with. If ACA were to be stripped and other alternatives put in place, we would just have to think about ways in which we're intentional about the care and coverage of those who are in vulnerable positions. And this means vulnerable geographically, whether you're in rural areas of the United States. This means vulnerable in terms of economics. Those who are, again, low income tend not to have high numbers when it comes to access and coverage. And considering that sickle cell disease is a disease that unfortunately requires such high utilization and such high costs, not only to the healthcare system, but to individuals and families as well. There has to be a system in place that's thoughtful about these particular populations.